Okay, so this is Senate Appropriations, and we're continuing our work on the 25 budget. And we're now taking testimony from the Department of Health, Commissioner here, to present Department of Health budget request. So welcome this afternoon. And I guess we'll let you take it from here. We do have this document that
Good.
I guess you would like us to refer to them.
Yes. So, good afternoon, everyone. My name is Mark Levine, Commissioner of Health. I'm joined by my financial director, Ann Swenson. And,
Is Paul Daly still?
oh, he's still power in our department.
My goodness, oh goodness.
But this responsibility is Aaron's, yeah. He has made the journey through the committees. I'm going to be doing most of the testifying, but there are some aspects on the budget worksheets, development workbooks, that deal with some of the more technical aspects that Anna will join in. Depending on how much of that you want to hear.
That's what I was about to say. You're gonna find, as you know, this committee tends to want to really have an opportunity for, we certainly know that ups and downs and so forth, but the major pieces, and then also what you have here is some of your highlights as well. And
Yes.
so we don't need to do a line by line for example, on your different appropriations, but certainly rely on you to sort of extract from us what you think.
Yeah, we know exactly what you want. We'll be able to provide it. So the picture is worth 1,000 words. So this slide is really the.
And how do we know where it is?
She's talking about the cover photo.
Oh, cover photo.
Your backyard or?
No, it is not my backyard. It is a health department owned shot. I don't even know where it is.
But it is Vermont, I would know.
It is Vermont, God forbid.
Yeah.
But the picture I was talking about is the pie chart.
Oh.
And so, this is actually the second largest budget we've seen. I think last year was the highest. This one's just a tiny bit lower, but when I started coming to this committee not too many years ago, we were usually talking in terms of $150 million annual budget. Now you can see we're 212. The box is really the key data. The current service budget is fully funded. There's a state dollar increase of 5%. Now, if you look at the pie chart, as you know, general fund is a minor slice for the Department of Health.
Has been historically.
Historically, exactly, because we rely tremendously on federal funds, most of which come through CDC, but lots of federal funds and through global commitments. So the state share of this, if you will, in general fund has increased ever so slightly. As you saw, the 5%, which really is more a reflection of the fact that the federal share has shrunk overall. And that's because we were in a time of plenty with all of the COVID funding. And now that is beginning and continuing to evaporate. So over time, that will play a smaller share. So it's about a 6% drop from fiscal year 24 to 25 in the federal fund. And a very slight increase in global commitment. So that's sort of the overview, if you will. Okay.
Year 212, which is.
We have 3 appropriations: administration support, public health, and substance use. So starting with administration support, we will go to the worksheet, but bottom line is we're going to focus on the orange line.
Yeah, so all of the line items under personal services and operating expenses, that's just your normal salary fringe changes and changes to internal service fund charges. So we thought we'd focus on the line items that have more, programmatic or technical significance. So we'll explain this on the next couple slides.
Well, it's pretty minor. I mean, the numbers, except for the 9 million, are really
Yeah, so that.
I don't mean to diminish.
And that's what we're.
Yeah. That's the first highlight. So, as Dr. Levine had mentioned, we're starting to see the federal grants that we received for COVID-19. We're starting to see those come to an end. So that's the first, this is the first example of that in this budget. That we received a supplemental one-time award to address the health disparities associated with COVID-19. That grant was awarded to the department in June of 21. It ends in May of 24. So this down of $9 million reflects the end of that grant.
I've made reference to this before on health disparities. Did you go to UVM medical school?
No,
Um,
University of Rochester.
okay, I've mentioned this to Senator Lyons as well. Back in the early 1900s, there was, schools, universities were looking at ways to reduce costs. And there was this consultant, Abraham Kleckner.
Reflects the report.
Yes, okay, and, in that report, he really recommended the closure of medical schools. And in New England, it should be Harvard and Yale, and Bowdoin had a medical school and closed it based on that recommendation. Dartmouth closed their medical school for 60 years. UVM did not accept the recommendation, but nationally, many of the medical schools that were closed educated Black physicians. And it brings home sort of and it was short-term financial expediency at the time, but the implications it has even today in terms of physicians that are educated, culturally sensitive, part of that minority population and a commitment to serve that group of Americans. It really is, it was a wonderful article. It was in the UVM College of Medicine quarterly, several.
Yes.
I didn't know if you saw it or not,
Yeah.
but you're obviously familiar with the report and this
Oh, yeah.
gentleman who had a profound influence on the education of physicians in this country.
And I wish I could tell you we're producing more diverse physician workforce today than we were then, but I don't think we are, which is really tragic.
Yeah, and of course, those would have been, not probability of going into primary care. And,
Exactly, serving the communities. that
Yeah,
come from-
yeah,
So we might have a bill for you to comment on for
Okay.
international medical students,
Okay,
international medical doctors coming into.
oh, St. George, there's actually medical college
Yeah,
there.
no, I don't.
Folks who
Yeah, I
are
bet you have.
Well, I haven't.
coming
been
to
the-
Vermont, migrating to Vermont, and
yeah,
they practice, there's a great bill.
okay,
There's a Grenada and,
Last, when the war was there.
yeah, well, they have a big airport there, that's true. And there's also a for-profit medical college, Ross University,
Yes.
on Dominica, and they have a veterinary, school on,
right.
St. Kitts.
Some of them have affiliations with US. medical
I'm sure
schools.
they would, but it's kind of interesting.
Yeah,
Well,
they've evolved over time.
Uh-huh.
It used to be sort of like
Yeah, don't.
hands off, but now things have changed a little bit.
Well,
We have duels.
we're back to Joel.
Don't get them started.
And
Oh, Sarah, well,
doulas
you can't let that one go, right? All
are you
right.
talking end-of-life doulas or regular birth doulas?
No, looky here. All right, so let's keep going. Anyway, when we're talking about health disparities, it
Yeah.
sort of brings home, and for those of us who are making decisions, the extent to which we make maybe short-term expedient decisions or whatever, but have very, very significant long-term implications. But anyway, I found the article.
Yeah, well, and just to link it to the monies that we get, and will not get as much of. We've really built up a robust infrastructure within the health department for health equity. And embedded health equity across the department, no decisions made without looking at it through a health equity lens. Grants to community organizations to carry out the good work of health equity in the communities. none of that's disappearing, but it's going to shrink compared to where it started. So COVID was a really good thing in terms of exposing all of this. But it's also now because of expediency, some of the really good investment is atrophying.
But you've actually integrated those principles in how you do your daily work,
Absolutely.
which is the long-term
Yeah.
benefit of that.
And we've tried to, if I could use the word infect, all other sectors of government with that philosophy. And indeed, we restarted the Health and All Policies Task Force last week. And that's another effort of building health equity across all of state government. And especially in terms of decision making.
Well, now we'll get back to cold cash here.
Yeah, so cold cash, so we're done with the 9 million, so.
Yes.
So the next one is not a lot of cash, but it is a
Forgivable loan.
a new thing, so to speak. It's an old thing, which is the Vermont Nursing Forgivable Loan Incentive. The new thing is a base global commitment increase of almost $300,000, which brings the base appropriation to $3.38 billion.
And
People often ask, like, does this work?
is this through APAC that these,
This is through VSAC.
this is VSA,
Yeah.
VSA, okay. Oh, yeah.
But we often get asked, like, what are the outcomes? And of course, this is a program that began in 2021, 22, so it's hard to give you big outcomes, because a nurse essentially gets payment for a year of commitment to work full-time as a nurse in Vermont. So I can give you short-term outcomes, which is this has uptake. So, you know, going from 83 awardees in fiscal year 22 to 150 in fiscal year 23 to now 190 in this fiscal year, which isn't yet over. And most of those, but not all of those, are unique awardees. Some are 2 years instead of 1 year. So we're reaching an audience with the available money. The money is being used. But the real thing states have to ask, because they're all competing for a finite work pool against each other, you know, with these kinds of programs, is do you have durable results where someone's going to say, oh, the year or two I spent paying back my debt, so to speak, by working in Vermont, said to me, this is the place I want to continue my nursing career and do it for, you know, decades, whatever.
Well, we tried to combine that with increasing capacity of our nursing programs.
Oh, yeah.
Which has been a real limiting factor as well.
Exactly.
Which also gets back to when hospitals actually ran their own RN programs and generated their own nursing workforce.
Yeah.
Which
Yeah.
we discontinued and moved to an academic model and
Right.
constrained supply. Very interesting.
Central Vermont does some kind of training.
They do now, they're starting it up
Part of that.
again, and try, for clinical, but we just approved, remember that simulation because,
Right,
for nursing for State College, because they, had difficulty with sufficient clinical placement, so,
Exactly.
we allowed them to use the money, as a way of addressing that shortage.
Mhm.
So I hope it's an effective, you know, method to, an alternative, I guess, to our clinical.
For their education, yeah. But that's what's happening with this incentive program that you. That's it for that first appropriation. The second appropriation is public health. And we do have, I guess, one technical change, which is just a move of the VPMS, the prescription monitoring system, from the Division of Substance Use to the public health appropriation.
Why is that?
Mainly because I guess the way I would frame it is it's really steeped in data and statistics and informatics. And that's where in our department goes
Am I
to.
thinking of two different monitoring systems? Is this where?
This is the one that
if
the
somebody
physicians
is-
have to look at if they're prescribing an opioid.
Right,
So if you're going to them for an opioid prescription, they find your name
And I'm
and see if you're
going
getting
over
it from
to-
5 other people.
I'm going to Brattleboro to get another prescription.
Right. Right.
White River.
This has been a successful program.
No, I know.
And Jim Letty was here, right?
Pardon me?
Yes.
Jim Letty was here.
Well, the history of it is interesting because during the Shumlin administration, there was an effort to get law enforcement access to this, and Pew refused, and we got.
Well, so did health and welfare. But health and welfare wasn't thrilled with it.
But I do remember when we created this.
You weren't sure, no.
No.
But all this is doing is shifting it within our appropriations. It's not meant to have any other action. The program exists and continues to do new things.
I just wanted to make sure it's the same program as we had back then, and it was, if you look back at that time, it looks, I mean, our efforts in combating particularly opiate abuse was mainly focused on pills back then.
Exactly.
No.
So now it's much different.
That's right. And this program is
But
now
we still have,
expanded to other
pills
drugs.
still being abused,
It is, but if you look at the people who died of an overdose and what's in their bloodstream,
Right.
the minority are prescription.
Yeah, no, there's still some people
Some, but minority.
actually had it.
But now we're looking at stimulants and
Yes,
giving physicians an idea of how many stimulant drugs they
there's no
prescribe.
more scary drug in my mind than methamphetamine for the user.
Yes.
They are,
More than
More than that.
xylazine? Really?
Oh, yeah, I mean, oh, yeah.
Well,
from the public health point of view, xylazine causes all kinds of problems, but I'm talking about, particularly mental health issues.
Behavior.
Behavioral issues from that, there.
also just their environmental disasters where they
And
make,
not only that, you have.
and then of course
the-
child welfare.
Well,
and-
Right.
Yeah.
It's dangerous.
Uh-huh.
No, that scares me more than frankly, other.
Well, on that encouragement, no, why don't we move to number 2?
Yeah, because this is the flip side. This is the good news on drugs. The unused drug repository program, which you've heard about before. And this is now where the funding element is coming in. The appropriation of 355,000+ from global commitment investment really is the way the program will be implemented. Using a contractor, et cetera.
To recapture those unused drugs.
Right, well, this takes drugs that might have been in a hospital setting, might have been in a long-term care setting, might have been personal use if the person perhaps died of cancer, but they still had drugs left over from that. But it's not opioids, it's only other types of drugs that aren't in the controlled substance world. And these are all quality controlled, making sure they're in tamper-proof kind of foils and what have you. There's a clinical pharmacist whose actually job is to make sure that they can be safely given to another person. And of course, the benefits are on the slide in terms of the health benefits for people who might not have even been able to obtain these, the economic benefits, of course, and the environmental benefits in terms of not having to throw drugs away that are perfectly useful. So this is a great program and it's a pretty minimal investment. Think about it. And it will become real this year.
Now the operating expenses.
Sure, so next we have, essentially a technical change, so under the operating expenses nature object, we have a special fund reduction of 1.98 million. So this line item essentially removes a duplicate appropriation, that was, essentially appropriated twice, once as a one-time appropriation in Act 22 of 23, and then also in the 24 budget. And appropriations from that fund are going to be one-time going forward, so this is a technical correction to remove that duplicate
Who
appropriation.
gets this money? Who receives the 1.9 million?
It's funding, this is the 1.9 million in Act 22,
This was the deluxe.
the unlocks and
Yeah,
expansion.
so this is
The no-lox,
the deluxe.
but it's one time.
Yes,
What are we doing next year? When we might still need it?
We-
Probably the opioid settlement.
we have opioid settlement.
Yeah, well, we just ran into a problem with one-time money. People use it for ongoing expenses, so I really worry about that.
Well, the
Yeah,
opioid settlement money is gonna flow for how
But the
long?
legislature did.
18 years,
18 years?
some
Yeah, but
parts of it.
Oh, sorry.
My point is, you're using one point, I'm sure we're gonna need naloxone next year.
Yeah,
So you're using one-time money to fund something that's gonna be ongoing. And I'm trying to, Senator Westman and I are trying to deal with certain groups that used one-time money for ongoing expenses, and now they're saying, well, we've had a 500 and some odd $1,000 cut. Because the one-time money's no longer there. I just want to make sure that we're not setting something up.
I really don't think we are. A lot of the money we got for naloxone, we didn't even need to use immediately because we had other sources of money for naloxone. Some of the one-time aspect is actually, we'll call it infrastructure, like the vending machines, investing in the cost of the machines. But the drug itself won't be a big issue.
And that.
We're giving out
might be for 18
record
years
numbers.
then. Well, actually. I guess maybe this gets into the other division, but we don't wanna forget. Trying to understand what's happening with, syringe.
Well, we'll get into that, because I know you're interested.
Well, we're trying to fully understand
Yeah.
what's happening.
I can
So
very,
the first one is simply remove a duplicate appropriation.
Exactly.
Second, the last one is what Senator Sears was saying, one-time money, but if we're getting this money, and it seems like this would be a high priority for the use of that funding for as long as we have, and
Well, it looks
18
like the
years.
legislature forced us.
What? What do we do? How?
We passed it.
Well-
Fiscal year 24 budget. We did it. I don't know what they recommended.
Well, if we did it with the understanding the money's gonna be there for the next 18 years,
Right.
that's probably as much assurance you want to have in a fight.
Probably more than most funding.
we have at least 7 or 8 settlements, they don't all run 18 years, but.
But the other thing is to, the thing that I would like to do is to define some of the funds for a revolving low interest loan, or pilot program for recovery programs, so community recovery or residences. And so have the opioid funds supporting a long-term investment on recovery, and it's still there. You know, all of the short-term things are great, but they aren't gonna solve the problem. But if you have some longer-term investment, and I know the advisory committee hasn't, I don't think they've advised that yet, but we're gonna have a conversation in our committee about asking the advisory committee to set up one like that, because, you know, doing this is great, but after a while, you run out, and you have to solve the problem.
I'm gonna address just what you said
Oh, good.
last.
Oh, good.
At least the naloxone keeps people,
Well, it keeps them alive.
yeah, while we're
Right.
trying to
Yeah,
figure it out.
exactly. No, that's the whole thing. That's short term, it's short.
And. Okay, other questions on this, you can move on to 312, that's your grants.
Sure, so we have three highlights in the grants nature object in public health. First, as we saw in the administration and support appropriation, a reduction in federal spending authority associated with the health disparities grant. This amount is a reduction of $3 million.
It's different than the 9 million one.
It's the same grant as the $9 million reduction. We just have spending and both appropriations related to that grant.
So is it a total of 12 or it's 9 here and 3, 3 is part of the 9?
It combined is 12, and that's the amount that was built into the budget for grants. And next we have an increase in interdepartmental spending authority of about $3.4 million. This is related to a memorandum of understanding that the health department has with DCF related to preschool development. So spending authority to spend funds received from DCF under this MOU.
Senator Lyons, you have a better understanding than I do in terms of what the, what this preschool development funding is directed to, or maybe I should ask the commissioner.
So this is money that comes from DOH to go to DCF,
No,
or vice versa, but the reverse.
Yeah.
So it's for preschool development? I'm not familiar with that.
I don't know, it's.
Maybe,
We can follow up.
Yeah.
I'm just,
Yeah.
I don't have any
Good question.
context to put this in, that's
Yeah.
what I'm struggling with. Okay. Family planning, on the other hand, I understand that.
Yes, this is a
All in favor of
VAA.
it?
Yeah, those transfer funds that you have.
It's net neutral, it's just moving it
Not neutral,
to Viva.
we're in favor of it.
And you still have your Title 10 that you're administering.
Well, that's what I means public health, and I asked something a little about that.
Sure.
Yeah, so. And as we move past public health, vaccination rates, where are we with that? And I'll tell you a little bit of my concern in across Europe, and in Canada. What they saw during COVID was a drop off in vaccination in other areas. And in Europe, there were 30,000 cases in the fall of measles particularly. And there's been outbreaks in Western Canada and if I'm not incorrect, something in Quebec. And where are our vaccination rates, particularly with kids?
Yeah.
Should we be concerned about ourselves? Did vaccinations for other things drop off during COVID for our own kids?
Sure. All very good questions. So we have a report I'll send you that I can encapsulate it here. Bottom line is, everything you said is true about vaccination rates going down during the pandemic globally and nationally. Vermont is holding its own. If you ignore COVID for a moment and just look at sort of routine vaccinations as they're called. Our measles vaccination rate is still at the level it needs to be to prevent a major crisis in measles. Doesn't mean that-
What's that level?
You have to have 95 to 97%.
Yeah, so we're in the 95.
We're in that.
Okay.
As you know, COVID vaccine uptake has dropped plummeted everywhere. We still lead the country, but we don't brag about our numbers because they're pretty sad. And especially in kids.
I got mine.
Yeah, well, our best rate is at age 65 and older. However, in kids, not so high. But there's a little bit of debate going on now about, well, maybe kids, that's okay, because the virus has evolved. And it's a different virus than it was when we wanted everybody to be vaccinated at the beginning.
I made the mistake of getting both the flu and the vaccine at the same time, and now I don't know which one was knocking me out.
Yeah,
I did the same thing.
Yeah, I was out for about 3 days.
but you haven't had respiratory.
I haven't had any, no, I haven't had the problem, but
Yeah,
I don't know which one caused the,
You almost
Yeah.
died.
that is
no, it wasn't that bad. Just felt, you know,
Just to expand the conversation, so we meet with the institutions of higher education every other month now. We've been doing it literally weekly during the pandemic. And we have a whole plan with them because, of course, kids come to Vermont from all over the country and world at times to be in college. And we'd like to think their vaccination status is where it should be, but with exemptions in various places that don't have to be. So we have lots of plans with our epidemiology section about what we would do if there was a single measles case, because one case is an epidemic. Measles is so contagious. And the colleges are pretty much versed in this now, so there's a very tight connection. So if and when that would happen, we'd be prepared for it. It doesn't take away from the fact that vaccination rates worldwide have not been as good. And now, the reason they're not as good is really the disinformation campaigns.
Well, I'm somewhat worried about that there, but I suspect everybody around this table gets contacted periodically by people that are anti-vax still.
You know, the politician that paid $7 million for ads in
Oh, really?
Robert Kennedy.
Yes.
He's been here.
Yeah,
His ad was on the Super Bowl the other night.
yeah, his family's trying to
Well, he didn't
but
pay,
that's-
somebody paid.
Well, but it doesn't, but, right,
name.
Yeah,
it doesn't, take away from the fact that the ad was on the Super Bowl.
right, but, you know, we're doing okay with our kindergarten age and our school age.
Where we are probably still not doing well, if you're looking at those indicators, is smoking rates of pregnant women.
Don't remind me, yeah. No, you're right, but it's not for a shortage of programming.
No, but we, you know, as a state, it just seems like, you know, we're one of the dual, well.
It's the rates of all substances in pregnancy.
No.
Right, yeah, I know. Oh, Ginny's got good humor, I can say that.
Thing.
But Ginny knows that programs like, the nurse home visiting programs in the pre-birth and just after birth range, adult study program, all of those are, tools to try to make sure that we identify these problems and work with people in constructive.
You know, actually, I would love to see just in a one sheet, what has been the outcome from those investments, and you probably have them, but one of the things we're concerned about is number of children brought into state custody. And, you know, I mean, that is one of the interventions that has been funded to make sure that children are safe and that we, I mean, it's a very significant act to remove a child from a home. And so it's just, and we're an outlier. The number of children we bring into custody is historically was very high. And the University of Vermont looked at that, and part of what they found was that we needed to make more investment in prevention. And this certainly was an investment. The question that comes back is, what are those metrics to determine what progress we've made? Obviously, you know, reducing the number of kids that come in or the rate that they come in is one, but there are certainly others. And so, it would be helpful, obviously, fidelity to the model is really key. If you're gonna get that, you know, what evidence base indicates. So, it's, on the other hand, if you're dealing with addictions, I don't know to what extent that influences outcomes. It's just, it's a source of concern.
Yeah.
And I will go back, and I have to say Howard Dean back in 1995 indicated his concern about oxycontin oxycodone in Appalachia. And at that point,
98.
we put in limits on how many, when a script was written, how many could be dispensed at any given time under the Medicaid program for that very reason. But you think about, in 1995, we were already having the benefit of that addiction in that part of the state, and now, I mean, it's, and that obviously may have helped some, but it of course.
I can tell you, we do very well when the problem is identified in pregnancy and it's managed. Whether it's nicotine addiction or opioid addiction, we do very well. It's postpartum over time relapsing and going back to the behaviors that preceded the pregnancy.
And,
And that's the challenge.
and the secondhand smoke, it's obviously there, after the child's born.
True.
Oh,
I will say, I just looked up DCF and Department of Health, and there's a link, boom, right to the Department of Health. With different,
that gives us the
Sections.
information that we're looking for.
the preschool development rate, so it looks like it's all linked into some of the early development, early childhood programs at DOH, yeah.
Well, you can give us a synopsis then.
Would you like to change? See?
That's it. Nope.
All right, we're into substance,
Now we're in our last appropriation substitutes, which we'll have.
which we've kind of
most
been talking
meetings.
about anyway.
Yes. Yeah, so the first slide is just the BPMS, the reverse of what was before, because we moved it from one appropriation to the next, so we can move on from that. And now we're at some of the grand highlights. Do you want to talk about the block grant, or do you know, and move on to the?
Yeah, absolutely. So again, we're seeing the end of COVID era supplements and one-time grant awards. So the impact, estimated impact from the substance use programs appropriation of those grants ending is about $6.5 million. So we have a reduction in federal spending authority for that amount.
Shouldn't think we're not getting federal money for substitutes, we are getting.
This was a
We
call.
have a constant problem that we've had forever, what to call this. Now we're calling it substance use program appropriation, substance abuse block grant supplements. Before it was the drug abuse program,
Right, say that.
ADAP.
Now it's
We have
misuse.
intentionally moved from ADAP to DSU.
Right, but it's still funky.
Yeah,
We should have kids, instead of doing some other stuff, maybe they can come up with a better name for it.
So number 2 on this,
yeah, so,
I assume this is to help the programs like Serenity and Valley Vista,
exactly,
that were, and great, and I was talking to, I guess it was Jack Duffy at
I'm sure.
Valley Vista. And they obviously were very concerned, and, they were dealing with also, contract and staff, but they also, which was troubling because they've been in the business a long time.
Yeah.
And they said the complexity of the individuals who are coming into their program today are so different than 20 years ago. And xylazine, people coming in with the open sores, one person was awaiting an amputation of a leg. And so it's, all of that is just so troubling to, see exactly what our treatment providers are experiencing today.
Yeah.
And I know that that you gave that response to them. I mean, obviously they were emailing me saying, we need some help here. We can't make this go. And, so I understand what this is
I
all
hope the email
about.
you're saying,
There, I mean,
They're still jacked up. Well, they had to come back because they
oh, they
originally,
came back.
yeah, because they had some, and they came back. So,
I remember meeting them at Conifer Park.
yeah, no, they're still there. I mean,
Yeah.
they had sold and then it sort of fell apart and they took back
right, they're very committed,
they truly are.
they are.
Yeah.
I hope they emailed you saying they were very pleased with the 38%
They
increase,
did,
because that's
they
what,
did.
that's what we heard.
Yes, they were pleased.
Yeah, and this of course is,
Anybody would be.
and this of course is, through the global commitment
Yeah.
funding process.
Yeah.
So
now we're going to get into,
yeah, now we get into some interesting.
why
Uh,
are we gonna talk about those syringes?
well, we gotta wait a second on those.
Oh, all right.
And this next slide is
Oh,
just,
number four.
Gonna get Bennington funded for its method.
so, we're gonna talk about substance
Oh,
misuse
not you.
prevention first. Which
Well,
is-
no, we've been waiting 10 years.
$3 million that legislatively has been allocated to prevention. The only change here is really in fiscal year 25, the full $3 million will be in base. It's been combinations prior to this. And in our budget, it's all GF based appropriation. We've done a lot of good things with this, which we could get into if you want, but,
Well, I guess this gets into outcomes and measure that. I mean, here we are,
Yeah.
20
Sure
years
you are.
later, we see where we are and raises a question about how we're designing prevention and what is working and what is not.
Yeah.
And it becomes hard because providers, once they start getting something, it becomes almost an entitlement to the funding.
Mhm.
And if you say, need to redirect it, I mean, then they start emailing us.
So this kind of funding is largely going to community coalitions, prevention coalitions based on a CDC model of strategic prevention framework.
Not
SPF.
aware.
And we have abundant data over the 20 years to show that when we have good funding in these pathways and in these coalitions, we see decrements in adolescent use of tobacco, cannabis, alcohol. Very
In certain
consistent
areas of the state.
where they have been located. We have great data. The second part of that is
So,
when those
what do the
fundings
coalitions
disappear,
do?
you see the erosion in the results until the funding is returned, and then you see the results.
I guess the question that I have is, many people that go to those community meetings are the same people we hear that are going to a whole host of other community meetings. What, other than meeting, what kinds of strategies, what kind of actually concrete activities are you seeing those community groups
Yeah.
initiate and
So
the effectiveness? So
a ton of this is third space programming, meaning summertime and after school programming. Because the time that's most dangerous in an adolescent's life is from close of school till 7 o'clock at night. And so, you know.
You just talked about that.
The Icelandic model, that kind of thing, where youth informed, youth empowered, youth buy-in, but adults and communities actually creating the activities and pathways.
where were you last week?
Yeah.
Yeah,
Senator Sears and I go way back.
No, this has nothing to do with
This is last
this. This
Thursday.
is last Thursday.
Plus, we're not using student SATs, are we?
Professionals,
We're
yeah.
not using them again, are we?
That's in the last slide.
Oh,
Yes,
good. When we get to that, we should mention that.
What, I thought we eliminated.
I thought we did too.
no, we're actually using some of the opioid settlement money to expand, because it's not learned.
Maybe if we keep trying,
Maybe,
No, I have to wait till the last slide.
okay.
I guess so.
Okay, but anyways, this slide was just to show you, the.
So you're saying exactly what we were saying last week in this committee. The issue was after-school programs funded through the cannabis.
Sales tax.
Mhm.
Senator,
So
I am also interested in the syringe and needle exchange.
well,
No,
we're
tell
we're
us.
waiting.
we're all waiting for the
We're
last
waiting
day.
for
No,
that.
no, because they're not.
Let's
Let's talk about
number
the.
4 on the next slide.
So my understanding is the money you're interested in is $500,000 that the House appropriated for the existing syringe service program.
And we did not put it in because our information from you is that you had sufficient funding through the end of the year.
Yeah,
And that you had a 300,000 and then you had a 400,000 from the opioid settlement. But for some reason, you hadn't got it out to the service
The
provider.
400
Yeah.
is what
So-
people are most concerned about. And when will that money be released?
my understanding is that money is out.
Those grants are actually currently in process and they'll have a start date of January first.
That's what we were told.
January first?
The grants,
Any costs incurred will be eligible back from the date.
When,
Back from.
understand that they will go back to January first, but when will they actually be able to?
Out.
Oh, the money,
As soon as the grants are executed.
like 2 weeks,
Yes, well, I had meetings with several groups about this today and, all of their hair is on fire. So, just wondering when that money would come in, then they have a request for the BAA, the conference committee.
That's the 500.
And we didn't include it, the House has it, we didn't include it because we got information from your department that between the 400 that was in process of going out, there was sufficient money for the end of the year. The problem was the money hadn't gone, I guess, is the slowness by which the money has gone out to the
Okay.
provider community.
And wait, for the provider community, not all of the distribution sites, but at least one of them is holding up and not handing out. So the question is, when is it going out and where are we?
So we need to get your date.
Yeah, we can check on the status of those.
And then would in fact, the 300 that was there, the 400 yet to go out will get us through and make sure that we have adequate funding through the end of this fiscal year.
Right, so,
And the understanding was that besides the 3 and the 400, that there was a federal grant that was supposed to end this month in that. What is that on top of that? Because if we're gonna end up talking about this versus the 500 in the
right,
in the conference committee on the budget adjustment. You know, it seems like 500 on top of all of that.
On top of 700, like,
Yeah.
how many millions of needles would that buy?
well, that's not their only business.
No, I know, but no, but if,
So I will tell you candidly that, you know, we recently read in the news about the St. Johnsbury site closing,
Yeah,
the brick and mortar site. But mobile gonna sort of take over for that, if you will. That's one organization in the state. It's really 4 organizations that run these.
with
So I can tell you that, we did not get a lot of earlier notice about needs to keep that site open. So that we could help understand and intervene in any way we could. So,
well, that's the site that I heard.
yeah,
And the inference has been because the 400 didn't go out, that's why it closed.
yeah, I know they have workforce issues. Like every sector, workforce. They don't pay a lot, so they have workforce issues, and they probably had brick and mortar issues like rent and things of that sort. Operation.
So what's the building used? What would they do?
So it's a syringe service program, so that people can come and exchange needles and syringes. They can get counseling. They can, if they are so motivated, connect to treatment. Because each of those syringe service programs connects people to treatment. They can provide for a whole host of social needs that their clientele will come to present to them and try to work with them productively. Keep in mind, these are people who aren't going to recovery centers. They're still actively involved in their addiction. So they're going to an SSP as sort of a trusted community.
Every night on the news. I mean, we're spending millions and millions in prevention and all these things. In that sad part, the number keeps getting higher and higher. I mean, is there any show of any decline at all in?
I'm sorry to interrupt, but I wanted to go to ice cream.
oh, wow, yeah, oh, wow.
I will go get some more.
Oh, wow. You don't have enough? No, there's 7.
I'm sorry, I'm sorry to interrupt.
No, this is fine. So
We don't.
let me just talk about the data for a second. So
You want something?
I'm gonna have,
you're referring to people dying of overdose
I'll
deaths.
have the job.
So we're currently
Knowing they're
right
coming back.
on par to be the same as last year. I can't say we won't be more than last year, but if we are, it'll be by a very small amount.
Where's Bobby's?
And the number of overdoses altogether, not just people dying, but overdoses in general, has actually gone down. Doesn't mean there isn't still a crisis. And we have a very, as the chair pointed out, we have a very toxic drug supply, which is killing people. And because of that, this is what you get. But syringe service programs are a way, they originally began to prevent HIV and hepatitis.
Mhm.
Because people were just used sharing needles and spreading really bad infections that could kill them by themselves. Now they've evolved to being a little more of a full service kind of center where people can go and trust the people they're interacting with and have some other problems resolved besides just exchanging needles.
Well,
This year, the whole energy in the room was on overdose prevention centers, which of course are a very different thing, also called safe injection sites. And so I think the SSPs kind of got forgotten in that. But I have to also say that the opioid settlement committee had no SSP come and ask us to make a recommendation regarding opioid settlement money to benefit their programs, which I've been an advocate actually of their programs. I think we should be using that in a much more profound way than we do. As you know, a lot of our capacity in southern Vermont is mobile, and in the very north part of Vermont is very mobile. And that's kind of a hit or miss if you're a person in the thralls of addiction and have to sort of schedule yourself to be able to meet the van when it's going to be in your community, as opposed to a place that's there all the time. So I think investing in that would be a positive thing. And I'm going to basically tell that community of
well,
providers, we're here to hear your testimony if you want a petition for money for.
I guess maybe
Subs.
that also raises the question about the recommendation of the opioid spending, the extent to which we say
Yes,
that's what it is or reevaluate.
so we can go into what those recommendations are now.
But,
This was the last year's, you don't want to rehash the one
so
from the year,
I guess,
but if you do, it's there.
so I guess what you're saying is when that 400,000 is going out very shortly, that will provide the funding through the end of this fiscal year.
I don't know if we can say that 100% because we haven't heard from the providers that that is true or not true.
I heard from several of them today. I don't believe that they think that's true, that the 400,000 would be enough.
Okay.
So
But they need to get it.
that's the minimum to avoid going out of business, basically.
Hmm.
I think what we need from the department is some sort of recommendation.
We will.
As we get to a conference
Yes.
committee, what do we say around that? It would be nice
Yeah.
to know what the federal grant was too.
Yeah.
To be able to create a whole picture of where we are.
Well, internally, we are meeting on this, so we will be able to provide that. We'll also need some input from that community though. Do you have a date that you need our information by?
Well,
By tomorrow? Yeah.
well, I guess, no, two things. If we, in fact, there's some confidence that the 400, once it gets out, will get us through June 30th. Then that deals with the BAA. It may mean, we have to look at it in 25. Or if we find before we get the 25 budget out more is needed, then we can hopefully scrape it together from some source and make it effective upon passage.
Yeah.
So, which would be May. So I would hope that between now and, well, January and May 1st, 400,000 on top of what's gone out would, work, but,
Okay,
um,
we'll get you.
Grady, do you want some ice cream?
Oh, no, we'll
Okay.
Very nice.
Thank you very much.
Thank you. What kind of ice cream is it?
It's from upstairs. I'm not sure.
Upstairs, I see.
Upstairs, it's from the Conservation Coalition.
Oh, you mean like, is it Ben and Jerry or Hoods or whatever? It's good.
Alright,
It's
again,
cold.
sorry.
Judge Wilcox.
So let me
Okay.
lead you through what we're doing with
And
what we proposed and sent in a letter to Senator Kitchell regarding the appropriations.
Yeah, I don't know if we sent that out to everybody.
So here it is on one slide, $5 million. And very briefly, the thrust of the committee, the first year, because people are dying every day, is harm reduction. And engaging people in treatment who, for some reason, could not engage. That's what we did last year. This year, the theme continued. But keep in mind, the continuum of opioid use disorder management goes from primary prevention through intervention, treatment, recovery, all the way. So, and as I pointed out many times, all anybody wanted to talk about was overdose prevention centers, which are not in this budget because the House bill actually has the funding for that coming from a totally different source. So though we could make a recommendation as a committee that this would be a wise use of the money, good thing to do in Vermont, we did not say use our settlement money for it. So here's what the settlement money is going to. Expanded methadone treatment access. So some of the hubs only have a certain number of hours a day that they will see their clients. And for people who are actually trying to like regain their life and have a job and keep their job and all that, going back and forth to a hub at inconvenient times clashes with that. Also impacts the amount of time that can be inducted into treatment, because the hubs are very specific on when you can come to the date for that. So Mayor Burlington originally took the charge of saying, we know we need more hours and we need help to do that. We as a committee and myself as the chair felt that's fine, but let's make it a little more open to the rest of the state, because other hubs who haven't stepped forward might through an RFP process say this is a good idea. Well, for us. So we expanded the amount of money to 900,000. There's two clinical initiatives in there. One is the Managed Medical Response Partnership. That's a partnership between Johnson Health Center and the Vermonters for Criminal Justice Reform, which is in Burlington, to provide medical care for the individuals coming there who want other services. So think about the wounds they have from xylazine, conditions they have that they don't have the capacity or time to go to a clinical setting. They will actually have that clinical capacity at this setting. The Vermonters for Criminal Justice Reform for 150,000 also requesting support for just the work that they do, which is mostly with people who have come out of incarceration, trying to transition back to the community, have multiple responsibilities to agencies like DOC, parole, like DCF, you name it, and really need a lot of help. So that's what that's providing. The stabilization bed program represents people who commonly try to get into treatment and then fail, if you will, they relapse. And relapse is chronic. It's like people who quit smoking never quit the first time. It's always 6 or 7 times. But when you relapse in this, it's a very high stakes game. You burn some bridges perhaps with your treatment. You really need a lot of help to get back into a place where you can succeed. So stabilization beds for that, especially for people coming from recovery housing, but from any setting, really are critical. It's a bridge to getting them back into where they need to be.
So where do we have the stabilization beds currently?
So they will be created.
This is the creation of those
Yes.
beds, and do we know where they'll
Yes.
be created?
Some of them could be created actually in existing residential facilities.
Okay. So could be a recovery center.
Yeah, recovery center wouldn't do that, it's not.
Well, we have recovery houses now.
We do, but these people would have probably been kicked out of the recovery house because of what they were doing.
Because of their relapse.
So they
So-
need, they need a stabilization.
Who is identifying the place?
That's the work that's going on right now.
Okay.
Good
Who's
luck.
doing that?
DSU with the treatment community.
Well, that's
So
a
we're
challenge, let me
Yeah.
tell you. We've seen that with mental health, programs.
Yeah.
We've seen it with obviously our juvenile,
Yep.
uh,
It's a good thing.
training.
Yeah.
I think it's something that has been missing for a long time and
Yeah.
we were too stupid to think about it. Backyards. Then we have contingency management, which we funded last time. That's the reward reinforcement program for people on stimulants like meth or cocaine. And that's just to continue their funding because those things aren't Medicaid reimbursable. And the programs require.
How does that fit with the contingency management on the preceding page that we were just on?
That's the same thing.
That
was the-
Now it's
That
1,600,
was the previous year.
so,
This is to continue that program.
okay, this was 23, this is 24, so you're actually cutting it by 40,000.
Maybe we are,
On page
that's okay.
25 up for.
I'm
by
on,
25.
looking at,
Yeah, you're probably right. That was.
it was 840,000, now it's 800.
Yeah, and the 40 was the training.
By the way, the test strips, I wanted to mention that are on the other page.
Yes,
If anybody from your agency has spoken to the Department of Public Safety, their testimony has been that fentanyl is now showing up in 100% of the glassine bags. I don't know if you even have to test it anymore.
I agree.
And xylazine is actually showing up in what's it, 53 or 60, 50-something% of the
Yeah.
glass.
That one might still be worthwhile.
That might be worthwhile, but you don't really need to test for fentanyl, it's there.
Exactly. We almost don't need to test these people who died of an overdose because 94%.
Of xylazine.
Fentanyl.
In combination with a bunch of them.
Right, xylazine is the one that
Yeah, xylozine's like 37.
can't use, but you can't use Narcan. Narcan doesn't work with xylazine.
Exactly.
Anyhow, I just thought I'd mention.
The last two are the important things to discuss because they're a departure from harm reduction and treatment. So recovery housing supports, 325,000. Turns out when you go into recovery housing, it's not like somebody hands you a check and says, this will pay for your rent for a couple months. You know, here's the room and board. People have to actually come up with that. So at a time when their life is so destabilized as it is, we wanted to provide stipends, scholarships for the beds that we do have, so that they could get into those beds,
And for recovery.
have a roof over their head, and get a job and begin life.
So we have a report,
Check.
the report that you sent out on that
Hundreds of them.
indicates.
Oh, yeah.
Yeah, how much money is going into that. So, yeah, that was very informative.
Yes,
Well, I'm
this
just
is a
trying to,
different part.
I'm just trying to
Yeah, no, I
crosswalk
understand
that though with the recovery, center and the recovery houses that we funded in this year's
And
budget.
also the pathways.
Yeah.
So,
Yeah.
Right.
yeah, well, right.
This is the fund to actually, the client who's entering.
So the recovery houses that we funded last year,
Mhm,
the
$1 million.
yeah, the people have to pay for their room and board.
Yeah,
Number 7 takes us by
Yes.
surprise, because we thought that SAPs went out a long time ago. And, I know that other people have come in, obviously the mentoring folk have said, we think, you know, if you want to look at average kids,
Yeah.
our volunteers really can, be the positive adult in their lives, so. When did we put SAPs back in again? Because it seemed like.
They
we
snuck
thought they
them in
were-
there.
yeah, well, forgetting about this money, they're already there. The problem with them, from our standpoint, is geographic equity.
We thought we had eliminated
So
funding.
I'd like to
for
hear from
SAPs.
Senator Sears about what was wrong about that. That made you look at,
Well,
why are they doing this again?
The effectiveness
Hmm.
compared to other providers.
So this
Like
is,
mentors, like
Yeah.
Big Brother, Big
Yeah,
Sister,
yeah.
other programs and the effectiveness. They were school-based, obviously,
they are.
and
Well,
many
it didn't
times,
necessarily have to be
based at the school, but.
Well,
But they are, I mean,
they are.
they're trusted by the students.
And it seemed as though many of the kids that were being guided weren't the at-risk kids.
Okay.
Well, can I ask a question?
Yeah,
So
That
are
was
these,
my impression. There were other issues, but
Ginny is.
Jimmy's got a question and then, but I wanted to let Dick finish.
Yeah,
and then
no,
we'll
let him
go to
finish.
Jimmy.
yeah, no, I think I'm finished. Those were the main issues, but I'm not sure they were always back in the day, we're always dealing with at-risk kids.
so are these student assistant professionals the ones that we're seeing going from, for example, I know in Addison County, there are some mental health counselors who are working with kids who are come out of the CSAC and go into the middle school and treat the kids. Are we talking about those counselors who are hired by the school, separate from school counselors? Or is this, this is happening now?
yeah.
We don't know. Okay,
I mean, they are still called student assistance professionals.
okay, but
SAPs.
I'm just trying to figure out if they're the ones that I know about have masters in mental health counseling and they're working with kids with behavioral issues or family problems, in school.
I think we're talking about the same thing,
We are, but then.
but
is
we're
this
talking
going-
about them in a limited number of schools.
Yes, but so is this funding, for example, our DAs hiring
Six
folks
months
from
beyond
our
the-
designated agencies to go into the school?
I don't.
Or is it separate funding?
No.
Okay.
Just a second.
So the schools are hiring these individuals?
That's my impression.
That the state is paying for. That's where the,
Absolutely, the kids really need it, but it's just like it's a
well,
whole
they need
separate
something,
program
but is
from
it that?
counseling that's not included in school budgets.
Right, but is it, they need, I don't disagree that they need
Yeah.
things. Is this what they need,
And the,
given the record?
and the other thing is the advantage of going through the DAs is that we are able to match the money in Medicaid.
Right.
And then you also have the clinical support that you would have, in an agency, as well as some collegial, support as well. It just seems like all of a sudden we're deja vu all over again. Because we had a lot of discussion about, these, positions and where money would go. And, so I guess this is, what we're talking about is an expansion of something that we thought didn't exist anymore. I think that's what we're struggling with here.
Taking me back 20 years here.
And it's not just the student assistant professionals, there's other school-based services and curriculum items. that are
I'm not opposed to school-based services. I think it's the delivery of those services to make sure they get to the kids that really need it. And furthermore, that, come out of something like the mental health center, the DA or some other organization that has the backup of the clinical and other services that the kids might need, or even the family services that the kids may need. Because as you dig deeper, you find out maybe the problem isn't with the kid, it's with the family.
Believe.
We all know that.
You're right.
The settlement committee did hear a lot of testimony on these and were convinced in terms of the way they prioritized things. These weren't the highest priority, but they were in the priority.
So
scheme.
this is their recommendation.
This is their
Okay,
recommendation.
but I guess we need to discuss,
So we can get you aspects of the presentation that at least will tell you.
Yeah.
Status now and what this would improve it to. So that you can at least be reassured that the status now may be better than you.
It might have been better than it was 20 years ago.
I would hope, yeah.
okay.
I mean, I know a number of these SAPs and they've got really important positions in their schools.
Yes, they are.
And they're very well respected. Their principals and their faculty love having them there. The students have faith and
Well,
trust
how
in
many
them.
do we have? How many do we have
Oh,
now?
it's not even a third of schools.
Okay, well,
But now the school day,
Be nice.
the school day we haven't extended that in 50 years.
Wow,
And kids are coming out of school not knowing how to read or write. And we're offering more, we're taking their schooling time away for things like this and.
well, more than 3 to 6,
Huh?
3 to 6 to 7.
Oh, it's at night?
Yeah.
Yeah, that's when these staff should be working.
The Dingy Sears skating,
Pardon me?
3 to 6.
But just to make a summary
That's when they
comment,
should be working.
All right.
the summary comment is primary prevention is a big umbrella.
Yes,
And this is part of the umbrella, the mentorship is part of the umbrella, all of the after-school activities are part of the umbrella. All the community coalition work, which is really robust, is part of the umbrella. It's a very cohesive package. And it really does work in total. It's evidence-based, it works.
So,
The fact that we have toxic drug supply and people are dying of overdoses shouldn't be misconstrued as saying primary prevention failed. We actually don't have huge increases in the number of people with opioid use disorder compared to what they used to be. There's a different formula for what they're using. They used to be on prescription drugs, then they were on heroin, now they're on fentanyl and methamphetamine and other stimulants.
well, it's also,
It's an evolving pandemic, if you will, but the reality is, it's not the failure of primary prevention necessarily.
is violent crime up for a shooting zone?
Yeah, that's another issue. Well,
No, I'm serious, I mean,
No, you're
that's
right.
the question, I mean, people are now shooting each other. Ever since I've been in Vermont, there's been guns, so. But they,
right, no, you're right, just like
no,
people never
people
used to
didn't
see,
shoot them.
and people
I'd
never
rather
used to
shoot
see somebody in downtown Burlington or Bennington with a needle in their arms on the street.
Right,
It was done somewhere else and then, they weren't exposed to it. So does that mean there's more of it going on or it's just we now see it?
you
And
know,
it
see.
makes the average citizen say, I don't feel safe anymore.
Well, we don't know penalty
they
for
don't.
doing it.
Right.
You know, well, actually Burlington laid off a lot of.
well, we are seeing, we're seeing a presence of organized crime in very rural areas of the
Yeah, a
state.
lot of them,
And,
not one getting.
And the market's here,
Yes.
no question about it, and that's what people are seeing.
Or for the demand, they wouldn't be there.
And we're seeing, that's right, that's the thing, that's what makes it worthwhile. And rural areas are very vulnerable because there's so little law enforcement and
Right.
surveillance, and so we're seeing, little town of Stannard was basically terrorized. People were threatened with getting their house burned, guns were going off. Well, North Troy, even Harrison Avenue in St. Johnsbury, there was a gunfight, and so that is a level of violence that we
No,
have not seen.
absolutely.
And so that is creating a lot of concern around safety.
Yeah.
So
I like this recovery housing.
So what I'm gonna do is, it's 4:30 and I'm gonna just, like we've gone through all the slides that we finish up today and I'll let the commissioner.
Yeah.
I want to compliment the commissioner.
Yeah.
For being responsive to people in Bennington who've been concerned about the methadone clinic and the lack of progress on it. I do want to thank you for those emails and responses.
Fingers crossed, we're gonna have some,
I hope-
this,
I hope so.
this year for sure.
I hope so, but it's been a long time coming, but I think that at least you've been responsive to it. And they appreciate it.
And we will get back to you with the SSP and the primary prevention information.
Yeah, that would be.
And I'm gonna leave you with one word. Because it's a new word. In the vocabulary. You've heard it, because you've heard me talk. Syndemic. So now we are in a syndemic, which is convergence of multiple epidemics. Substance use disorder, mental health crisis, housing crisis, public safety crisis.
I'm gonna slit my wrist.
But they're all intertwined. And then, you know,
Suicide.
yeah, suicide, they're all intertwined.
I know,
And-
everything is
And
connected.
they're kind of connected to each other in different ways. Support one another, if you
So
will, in
if
the
we
wrong
go to
way.
our dictionary, we'll find that word.
I hope so,
Syndem.
because I wasn't the one who made it up.
What is it? Syndem?
Then-
Syndem, S-Y-N.
Syndem.
But not the demic of sins.
No, that would be
Have
S-I-N.
you heard about faulty counterfeit
Oh.
Airbag.
airbags? Yeah. Now, where are you at worrying about counterfeit airbags when all this is going on?
After hearing our testimony, you should have an extra dish of ice cream.
Oh, good, I need it. So committee, I'm going to adjourn for today. We'll go offline.